opium is still the major one. No, okay. So, and based on the data from World Drug Report by UNODC, Iran has the highest reported prevalence of opioid use globally, which is just interesting to me. That tiny country, but a lot of, yeah, it has the highest reported prevalence. And just so you know that how available opium is in Iran, is we have one of the highest rates of opium seizures. So in 2017, they seized more than 630 tons of opium yes, which is interesting to me. Cool.
All right, so next we kind of were interested in seeing kind of where you're based at, so what country you are based at, and if you know what kind of substance is most prevalent in your country, and if it is opioids, if you know the specific type of opioid, we will be interested in that. So if you don't mind just quickly typing in the chat so we can see kind of how the different prevalence of use of various substances differs across countries, and Kiana is going to read out what everyone types in the chat so we can see that.
Okay, so one person says I'm in Canada, pharmaceutical or illicit. So I think illicit use is more what we're looking for, right? If you think, if you know what is the most common illicit drug use in Canada. Another one, I'm in BC, Canada, and there has been a fentanyl problem. That is very true, yes. And we also hear Dr. Krauss, I think he mentioned it, or he will mention it too, that first heroin was contaminated with fentanyl, but right now some people actually seek fentanyl on its own, so which is interesting. Opioids, heroin are the most common, yeah. Another person is in Toronto, cocaine, crystal meth. Okay, so people in Toronto have a lot of money. Kidding.
That is actually the rise in stimulant use. I know it's an issue that's kind of happening in BC as well. We are seeing kind of rising numbers of crystal meth use. And in Iran, actually, there was also recently a systematic review that looked at kind of rising numbers of stimulant use in the country, mostly in the injection form as well. So that's also another thing that's quite interesting and different between Iran and countries like Canada. In Canada, we are seeing rising smoking rates. So even with regards to opioids, a lot of people are choosing to smoke opioids now compared to inject them. But in Iran, there's a rising prevalence of injection stimulant use, still not as high as opium, but it is rising. So that's really interesting as well, how that's happening across both Canada and Iran.
Yeah. And there is one last comment from an attendee working at a safe injection site regarding most used drugs. First fentanyl, then meth, then crack, cocaine, or just cocaine. No one in Ottawa does heroin. There really is only fentanyl. That is so interesting. I think maybe that's where Vancouver is going toward too, because now, as I said, first their heroin was just contaminated with fentanyl, but now they're actually seeking fentanyl. So maybe we are going toward that trend as well. That's why I love these workshops, because I learned things too. I did not know this about Ottawa. Yeah, but just one last comment, Kimia, and then we can move on. Smoking often is under documented because there are not safe sites for its consumption, which is true. Yeah. Okay. So that's the research idea if you're looking for a project. Okay, so this is me. So Iran has a unique profile of opioid use. We will see that mostly in a lot of countries, for example, cannabis use disorders prevalence, or they're using maybe not the disorder, but mostly they use cannabis. But in Iran, we have opioid dependence more common than anything else. And we will talk about the specific studies, but just so you know, most commonly used opioids in Iran, based on few studies that we will mention, is opium first, shire, I will explain in a second what it is, and methadone. And this methadone is not prescribed by physician, they found. This is just what people get from street. Um, Okay, so now about shire. So people in Iran, after they smoke opium, they get the ashes, and then from the ashes, they condense. They get some condensed extract, and then they use that. That is called shire. So at the beginning, shire was some like kind of recycling the opium they were using. So they wanted to like have more drugs, but by time actually some people started to prefer shire, so they actually wanted instead of the opium, they actually wanted that condensed extract of the opium smoked opium ashes, which is interesting. This is just I've just seen this in Iran, so I thought to share that with you all. um, I think we can go to the next slide. Yeah, perfect. So this is, as I was mentioning briefly before, it's in contrast with other places in the world. So cannabis is the most widely used drug worldwide. And also pharmaceutical opioids are the ones that account for half of the opioid consumption globally. For example, we see 81% of opioid use in North America is related to pharmaceutical opioids. But as you saw in Iran, it was opium, shire, and methadone. And even the methadone wasn't pharmaceutical. It's there, they actually get it from the street because of that high availability we talked about. So it's just another difference in Iran. Yeah.
Great. So I know a lot of you here are based in Canada, but Canada is a very multicultural country, and we were just curious to see if you know of any particular drugs, such as shire in Iran, that are culturally specific and unique to a particular region, that you might be willing to share with us. So I think this is a great learning opportunity for a lot of us, because I think there are a lot of culturally kind of significant substances out there. So yeah, Kiana, could you read out the chat for us as they come in?
Yeah, so one of them is hashish. It's a form of weed in Egypt, mostly used. Yeah.
That's interesting. Yeah, we actually came across also another type of hashish called charas that is hashish is essentially a form of marijuana, as our participant mentioned. And this type of hashish is particularly used in Afghanistan, Pakistan, Nepal, and India. So it is quite commonly used in those regions. Yeah, anything else that came in, Kiana?
Not yet. I think people are thinking about it.
Yeah, it's I think it's
And it doesn't have to be from your country. It can be like any unique drug that you know, like another country uses that you know about.
So one other drug that is also quite unique is khat, which is native to North African regions, particularly Egypt. And it's quite commonly used in Muslim cultures. So we thought that was really interesting, because a lot of Muslim populated areas and regions don't kind of use a lot of illicit substances that we see in the Western countries. However, khat is quite commonly used in these regions. So that is really interesting to see as well.
Yeah, and I typed the name of both of them, the drugs that Kimia talked about in this. Before searching for this workshop, we did not know about these drugs either, but it was interesting, especially with khat, because they see that, oh, okay, alcohol is not allowed in our religion, and then they have found this one as a substitute, which was interesting. But we have one more comment, Kimia. Sometimes people combine uppers and downers for specific experiences, and they call them speedball, dragons. Actually, I've also heard about speedball in BC as well. Yeah, which is interesting. There is one question. Why is alcohol not permitted in Iran? It's because it's taboo in Islam. It's taboo, like we can't have it, and because the dominant religion of Iran is Islam, then they have prohibited, and it's strictly prohibited. Like you can go to jail, and there are very, yeah, punishments for that. That's why the report of alcohol is very hard in Iran as well. When we want to look at it for research project, it's very hard to get data. Um,
And just to add something to that, it is one of the, so like Kiana mentioned before, opioid is quite accessible because of that route that goes through Iran. Alcohol is a lot harder to access. So it's quite expensive if you want to access it. And it is quite difficult to access it as well. So a lot of people don't use alcohol. Yeah.
Yeah, and just one more comment and one question, and then maybe we can move on. In Indonesia, a drug called sabu sabu, maybe, is meth. It's kind of a type of meth. Apparently, it's very popular. I did not know that. I will look into it after this workshop to learn more about it. Um, so the question now is, and they think that opioids are better, as you state that it is acceptable. Yeah, that's a good question. So still all the opioids are illegal in Iran, but opium is not prohibited in Quran, like the book of Islam, and nothing about that is mentioned. So that's the religious part of it, but still all these opioids and opium, even though it's socially acceptable, they are illegal. But for opium, they've been using it traditionally for many decades for therapeutic purposes, and because it doesn't have that connotation with the religion, it's more acceptable to maybe to people in Iran. But you're right, it's a very gray area, so I like that question. That's something we can think about. Yeah, and I just wanted to thank everyone for participating. This was great.
Thank you, everyone. Right.
Okay, so now we want to go to different studies to just give us a better idea about opioid use in Iran. One of the famous studies, which is an epidemiologic survey on drug use in Iran, was from a survey called Iranian Mental Health Survey. They had 7,841 participants aged 15 to 64. And they did analysis, and they saw that this was a good representation. Yeah, it was representative of the population in Iran. So this is like one of the best studies we had available to talk to you about. And they shared a few results with us. One of them was opioid use disorder, where the most common form of illicit drug use disorder. So not cannabis, not alcohol, it was opioid use. And to give more specific percentages, opium was prevalent for 82.3% of these people. And then shire, which we talked about, was the condensed extract of the smoked opium ashes, was 27.8%. Methadone, again, not prescribed by a physician, was 16.6. And there's heroin with crack heroin, which I will talk about in a second, was 16.1%, and morphine was the lowest one, 2.6%. Now with crack heroin, this one I find that people find interesting. So crack heroin, or crack as it's called in Iranian drug market, is a heroin-based narcotic, not a stimulant, with a significant amount of acetylcholine combined with heroin, codeine, caffeine, morphine, and acetaminophen. And it's different from cocaine-based crack, which is known as crack in most other countries. So like in Canada, if we say crack, like we think about crack cocaine. No one thinks about crack heroin. Iranian crack is used both through sniffing and injection, and it's different from heroin because first of all, it's odorless. The other one is that it can be used by needle without the need for preheating. So for heroin, you need to preheat it, and then when it's melting, then you can inject it. But with crack heroin, it's just in a liquid form itself. So yeah, that's another one that is unique to Iran. Okay, perfect. And then from the same study, one thing that they found is that, interestingly, the impairment wasn't that high among people who had opioid dependence. So as you can see, for example, severe impairment was 25.9% of those people. But we have some hypotheses about this. We will talk about it later, that why impairment might not be that bad in Iran. And then the odds of drug use disorder, and opioid dependence were greater in men, in previously married people. So previously married, it could be either they got a divorce or their partner passed away, they're widowed. Low level of education and low socioeconomic background. So these are similar to other countries. This one was no different with Iran and other countries. Okay, and now this is the study I've been spending my last 3 years on. So it's a double, we conducted this study in the ACD research group. It's a double-blind randomized clinical trial with 204 participants in Iran, so basically we wanted to look at, we randomly allocated them to two different arms of treatment. One of them was with opium tincture, which is found in Iran, and the other one with methadone, and we wanted to look at the effectiveness of these two. But basically right now, I just want to talk about the demographic data that we got from that study, which is relevant to this workshop. So all of these these participants were from 3 different cities in Iran and 1 rural area. So all these 204 participants had opioid use disorder, and we found a similar effect as that epidemiologic survey you saw before, that opium, shire, and methadone were the most commonly used drugs. One interesting thing that we found is that lifetime overdose was not that high. It was 8.8%, which is, again, similar to the other studies. For example, from that epidemiologic survey we saw, they reported 9% of lifetime overdose. And also, their participants were socially functional, so they were 64.7% of them were married, and 61.9% were employed. We will talk at the end of this workshop about why we think these rates are high. Either they are socially functional, or it's like other factors that are causing these numbers. We will talk about them. And this is the graph that you see on the right side is from the same study. One thing I want to talk about is Norgizak at the very end, which we see that 5% of people have used. Again, this is something unique to Iran. So Norgizak is a combination of opioids with dexamethasone or benzodiazepine. and it's mainly injected and has been attributed to a wide range of side effects, including extensive skin infections and abscesses with corticosteroid side effects, significant risk of bloodborne infections such as hepatitis C, and increased mortality, but still some people are using it. Yeah, this was another interesting result we found. Before I move to the next one, there are just two things popped up in the chat, I think. Yeah, one attendee said, opioid use in men, wondering if due to loss of partner as a way to cope. Yeah, that's actually in my literature review when we were looking, one of them was this, that men, as they have different coping mechanisms as women, and one of them is use of drug, and you know, being married and then becoming single, like this is one of the hardest transitions. So that's a very good observation. And the overdose is just overdose, it's not death. So this is a rate of overdose that people had at least once in their lifetime. That's a very good question. With overdose death, as Kimia mentioned, there are, if you could find data on Iran, that would be amazing to share, if you could share with us, because with overdose death, it's very hard in Iran because they don't report it that well. But Kimia is going to talk about few studies about overdose death more specifically, and the limitations of that data as well. So we will dig into that deeper. Okay.
Great. This is one of these studies that we found that looked at mortality by substance use. So it was a cross-sectional study, and it was done before the opium tincture study that was done by the ACD group we talked about just now. And this one found about 2,986 deaths by substances, and this was all different kinds of substances, not just opioids. And you know, the rate in percent was so low that I decided not to include it. So instead, I just reported it per million because it made more sense. But essentially, in terms of population, it was quite a low death rate, which again, it could be largely attributed to low reporting of death and difficulty in tracking death by overdose in the country. Now, this study was done using one of the kind of larger databases from the Legal Medicine Organization. One thing that is really interesting that I want to draw your attention to, so you can see the trends of the various substances that are being used here. So we have opium as one of the highest, and then followed by heroin. And we have alcohol at the very bottom here. Now, if we go back to the previous study that we looked at, and this was done mostly from self-report. So it wasn't like a legal organization, right? We just conducted the study. You can see that alcohol is a lot more prevalent here. And the difference is quite a bit. So, you know, we are looking at a really, really great difference. Now, the study didn't discuss this in particular, but we think due to the legal nature of this database and organization, it may have attributed to a large underreporting of alcohol use within the database. So one of the things that we kind of discussed earlier was the issues with the legal situation in Iran and how data reporting is affected. And this is a really good example of where this might occur. And we really need to be vigilant when we are kind of looking at these data and interpreting it, because I do not believe this percentage is completely accurate. So regardless of alcohol, looking at opioid, again, this study found prevalence of opioid use prior to overdose was highest with regards to opium, and then followed by heroin. They didn't look at methadone, so we don't have data on that, but heroin and opium were the two highest ones that they found. And again, these are prevalence, not death. Death was quite low. So then the next study, and this is quite recent, it was in 2021. It was a retrospective chart review from 2012 to 2018 of all different drug-related toxicities. Now, although, as you can see, they did have quite a large number of charts that they did review, it was only based at one hospital in the country. So that's one of the limitations of data that we find. The ones that are collected appropriately and are usable in research oftentimes are not at a national level. So this is one example that you see only one hospital being included. Now, although there were like 9,175 cases of drug-related poisoning, you can see that the percentage of overdoses attributed to opioids were actually quite low. And the opioid with the highest prevalence of use in the country, which is opium, doesn't really have a high overdose rate. And methadone has the highest, which is what we would expect due to the potency. Now, on the right side, you can see kind of the trend over the years of how overdose rates are changing. And one interesting thing is that overdose by opium is actually dropping. But another interesting thing is that unlike what we see in North America, where kind of overdose by heroin tends to be quite high, you see that as relatively low over the years in Iran. So it's not really increasing, and both prevalence of use and overdose are staying quite low. Now, another interesting thing is that there was a spike in synthetic narcotic use. Now, this is not necessarily fentanyl in Iran, but what was interesting was that it took place at around 2017, which was also when we saw we saw the rising rates around the same time in 2016 here in BC. So kind of thinking about the global context of overdose and how it's affecting a lot of different countries, this was a very interesting finding to see happening at around the same time.
Okay, so before I go to my slides, I just wanted to address one of the questions in the chat. That they were wondering difference between opioid use among men and women. One thing is that women are underrepresented in the data sets from Iran, from what we have seen. From our studies, women were they less likely used opioids compared to men. So we had 13% women in our study, but 87% were men. And in the other studies, it was relevant, but again, it's because most of the studies are from clinics, for example, or hospitals, and usually women don't seek treatment because of the stigma. So it's definitely underrepresented. One interesting thing about their use, we didn't find many different patterns of substance use among women and men, but the behaviors, the risky behaviors was interesting, that it was men used to have more risky behaviors compared to women, for example, injecting, but women had injection less, or overdose. But women had less overdose. So it's just the risky behaviors or polysubstance use, mixing different drugs. It was more prevalent in men compared to women. So this pattern of use was different among them. But with substances, what we see is that women are either underrepresented or they are actually using less. There are two other things. Is there any data for youth? That's a very good question. That's not the area of my research. Like, we haven't looked at it, but it's very hard because with youth, as Kimia mentioned at the beginning, it's just so stigmatized that parents don't want to talk about it, or like the data around it is very low. So that one is very tricky. I don't know, Kimia, if you know more about youth.
Yeah, so Data-wise, there's almost nothing. So we did an international Delphi, as Dr. Kraus mentioned in his keynote, on kind of the youth guidelines and treatment approaches available in a variety of different countries. And there's almost nothing available in almost any country. And Iran is like at the very bottom there with nothing. But from my personal experience, I actually had a friend who was using opioids and he was taken back to Iran by his parents. So he was here in Canada and was taken back to Iran by his parents. And the approach that they took there, and I'm not saying this is the representative approach for everyone, but this is something that this family did that might be happening with a lot of families, was essentially just going with a forced abstinence-based approach. So going through detox, no particular treatment, and just stopping drug use and forcing that drug use to be stopped. So there's no for youth, really the concept of substitution treatment and allowing kind of goal-based treatment approaches with like lowering use rather than abstinence alone is really not founded, because there's so much stigma around drug use that families want to protect themselves and their children from that stigma. So they choose to just go the abstinence-based route. And a lot of it is forced detoxification without any follow-up treatment available. So again, that's from my own personal experience. I don't know if that's the case with everyone, but I do assume it is due to the social context.
Yeah. Yeah, and one other question I'm wondering regarding alcohol uses in Iran, is it underreported due to access or stigma due to culture, religious? Just curious. I say definitely yes, because first of all, in most of the epidemiologic surveys, and also the first one that we talked about in this workshop, they say that because of these cultural religious prohibitions, we exclude like they excluded alcohol reports altogether, because they were like they are not reporting the actual thing. And Kimia, if you go back to our graph from the study with Dr. Niku, we had alcohol, which you see it's yes, 39%. It's again, you see that it's very low. We included it because we thought that ours is 204 participants. We thought that this is going to be informative if we include it, but you're 100% sure, like a lot of them might also think that, oh, I'm going to report this, and then they might come and arrest me or something like this, so they're scared of reporting it too. Yeah, but mostly you will see in big studies, they say that we excluded alcohol use because they just know that they cannot get good data on that because people do not report it. So 100% I agree with you from my own experience, because I'm from Iran. I see that people use alcohol left and right, like it's everywhere, but yeah, they don't report it. Okay, I think we will go back to that. So one thing, yeah, no worries, you're welcome. One thing, patterns of opioid use is different from other countries in Iran, as we've seen. We just want to bring all the data together right now. So we see that in other places, global prevalence of opioid dependence is lower than Iran. You see, for example, in worldwide, North America, US, Canada, Europe is much lower than what we have in Iran. In Iran was huge. You saw opioid was like 82, opium, sorry, was 82%. Prevalence is higher in Iran. We see different patterns. For example, heroin in Europe and prescription opioids in Australia and North America are the most commonly used opioids in those countries. But in Iran, it was opium, shire, and methadone wasn't even prescribed, right? So we see that how different countries are different, and all these research projects, I think, are so important because they can give us a good idea of the context of all of this. And prevalence of overdose and injection is higher among patients with opioid dependence in Australia, North America, and Europe compared to Iran. So now we have some hypotheses, as I said in the next two slides about this, but one of them, it could be, as Kimia said, like the overdose rate is being underreported, like we're having difficulty finding these data. But the other one is also these reflections that we had, not just me and Kimia, it was with Dr. Kraus and Dr. Niku and people who are much more expert than us, is that we see they have high, people with opioid dependence in Iran have high level of social functioning. You see that in our research, and also in the other research we talked to you about, is based on their education, employment, house ownership, marital status. They are functioning, they are still married, they still have jobs around. So we might think because of this social integration that they have, maybe this is one of the reasons that is leading to lower overdose rates in Iran. But again, the reason of thinking about underreported data is also back of our mind, that this also might be happening. So you might think that why are they functioning very well socially, and this could be because of the traditional use of opium for therapeutic purposes for centuries in Iran, that brings to the fact that, okay, people are accepting it a little more. So it is leading to higher social acceptability and lower stigma towards opioid use, particularly the ones that are using opium. Now, just one comment about employment and marital status. When you look at studies in Iran with drug use, you see that most of them, as you saw in the research, the papers we talked about, employment and marital status is high. And you might think why. Well, one of them is this that we talked about, the social integration is high, but the other one is that employment in Iran, first of all, they don't have that minimum wage that we have in Europe and Canada, or they can offer you any money. They can offer you $1 for like a job that you do, so it's not. And also the screening process to be employed is not as strict as it is here, so people are more likely to find employment in Iran. So even though maybe they are not actually that functional, but they are finding employment because of these easier restrictions. And the other one, marital status. In Iran, with religion like Islam, and also cultural aspects, divorce is a very like thing that is very stigmatized. So people, even though a lot of them don't have happy marriages, they still rather be stay married. So this could be another factor that we see, that even though they obviously have opioid use dependence and they're using a lot of drugs, maybe they're not really functional in the society, but they still are married. Maybe it is because of this. So we want you to have all the possibilities, so we are not being biased about that. Oh no, we think that it's because it's acceptable and they are actually functional. It might not be. This is an area that needs more research to see which one is the actual truth about all of this. And the next slide. Yeah, and then the final reflections that we have is that, as we see, I learned so much when I did these research projects in Iran, that I saw that we have different patterns of substance use in different countries. We have drugs that we never even heard about in Canada, but they're in Iran. For example, crack heroin. Like, just as researchers, it's really important to know about these cultural differences, because maybe you heard crack and you think that, oh, it's cocaine, but it was actually in Iran is crack heroin. So I feel like it's very important for us to educate ourselves, not only just for Iran, but for different cultures, when we are thinking about these problems internationally, to think that different cultures, different countries don't have the same patterns of substance use. And there are differences based on their traditions. As we saw, opium, for example, was more acceptable because of that decades of therapeutic purposes that it served, because of higher availability and preferences. In another country, all of these traditions, availabilities, and preferences might be different. And the other thing is that I know we talked about the other factors, that maybe employment was high because of the lower restrictions, maybe marital status was high because of the stigma around divorce and all of those. But still, we see that from these studies that we had, that these people are more integrated in the society. They're not that isolated. The culture of Iran is more collectivistic, so they have that social support. So we see that, maybe the reason behind these lower levels of overdose is because of this social support and social integration that they have. So maybe this is something that we can learn to apply it for our own countries, like for Canada, North America in general. Well, my research is mostly focused on treatment and interventions. So one thing I learned about definitely with Iran is that thinking about the whole context is very important when we are thinking about uh, proposing effective interventions and treatment. So we can't, there's not one formula that can be applied for all countries, but it's very important to know, as you guys talked about, different genders are different. In our study, we compared rural areas with urban areas. For example, we saw that urban areas had riskier behaviors compared to rural areas. So that's also important when you're thinking about interventions. And yeah, just thinking about this whole biopsychosocial approach when thinking about treatment and interventions is important. Yeah, we are done. Any questions? And I just wanted to thank all of you for being here. We were also worried that, oh my God, people are not going to show up. They're not going to engage with us. But you guys were great. I learned so much from you all.
Thank you so much, everyone. We're happy to answer any questions. If you have any, feel free to unmute yourselves if you'd like.
Yeah, but if no questions, you can enjoy this extra time before going to, I know it's a long day for all of you. Yeah, thank you all for your time, for coming to our workshop. This was a pleasure.
Yes, thank you very much.
Perfect. I feel like no questions. Okay, we will let you all go. Thank you so much again for coming, and hopefully you learned something. Yeah. Okay.
Bye, everyone.
Bye, everyone.
For the rest of the conference.